Okay, for our spotlight debate, our question is, should we worry that pimavanserin might indeed increase mortality amongst Parkinson patients with psychosis? Our first speaker is Daniel Weintraub from Philadelphia, and he will be on the yes, we should side.
I'd like to thank the presenters, organizers of the meeting for the invitation to come and participate. It would be great if people wanted to move up a little closer. At the end, we're going to hopefully have some conversation, questions, discussion, but if people want to stay where they're sitting, that's fine as well. So I was assigned the position, should we worry that pimavanserin might indeed increase mortality amongst Parkinson's patients with psychosis? And the position I was assigned was yes. And Zoltan Mari is going to be my opponent in this debate, and he's going to present afterwards, and then again we'll have time for questions and comments. When I was thinking about this afternoon and discussing it with somebody, I was reminded that pimavanserin is only approved for use for Parkinson's psychosis, or really for any indication in the United States. So most of the people, or many of the people attending this meeting, perhaps in this audience, wouldn't have had any experience with pimavanserin, and it's not approved in your country. And by way of very brief summary, it's recently approved, recently being about 2 years ago now, antipsychotic, the only antipsychotic approved for the treatment of Parkinson's disease psychosis specifically. And it's also unique in its mechanism compared with other antipsychotics in that it's a selective 5-HT2A inverse agonist. So it doesn't have any effect on dopamine receptors. So here we are about 2 years later, and we're having this debate. So why is that, and why might indeed we be worried about an increased mortality risk with pimavanserin among Parkinson's patients with psychosis? First, my disclosures, and I have one highlighted and bolded in yellow, is that I have done consulting work for Acadia. So although I'm on this side of the debate, I've also had an affiliation with Acadia. So point number one in support of this argument would be that Parkinson's disease psychosis itself is associated with an increased mortality risk. So regardless of what you're doing to these patients or with these patients, the fact that they have Parkinson's disease and the fact that they have psychosis already makes them a vulnerable population worthy of special consideration. And that special consideration in this case has to do with morbidity and mortality. And just a little bit of data to support each of these points is that we already know that Parkinson's psychosis is associated with certain long-term worse outcomes, bad outcomes. One relates to institutionalization or long-term care. Another relates to increased risk of hospitalizations, including repeat hospitalizations. We also know that Parkinson's disease psychosis increases mortality, as I mentioned before, and this slide and the subsequent one are from the same study, showing that there are other independent risk factors for psychosis, for mortality in Parkinson's disease that we already recognize: male sex, increasing age, of course, more severe disease, dementia, but also psychosis being another one of these key clinical variables that predicts mortality. And if you look at it slightly differently, this is a Cox regression model looking at prediction of death in patients either without psychosis at baseline or with psychosis. And those patients with psychosis had a higher risk of mortality compared with those patients without psychosis. And that applied even to those patients that we sometimes deem as having benign psychosis, so hallucinations with insight. And you can see the mortality rates there. Those are the vertical red lines, approximately 40% at 3 years if you have psychosis at baseline, and 80% at 7 years. So these are very high rates of mortality in this population. Point number two, we know that antipsychotics in general, I'm not speaking about pimavanserin specifically here, but antipsychotics in general are associated with increased mortality in general dementia patients. Now, general dementia patients in this case applies primarily to patients with Alzheimer's disease. There's now an extensive literature from randomized controlled trials and also surveillance post-marketing data, case control studies that have found a consistent association between multiple antipsychotics or antipsychotics as a class and mortality risk in general dementia, or Alzheimer's disease patients. So this story started some time ago now, over a decade ago, with an increased risk of cerebrovascular events or strokes. That was the mortality risk, the morbidity risk, and also a mortality risk that was secondary to cardiovascular events and infections. These were coming again primarily out of Alzheimer's disease, agitation, and psychosis randomized controlled trials. That led the FDA in the United States to issue a black box warning, first for atypical antipsychotics in 2005, and that was extended to typical antipsychotics in 2008. We also worry about certain potential morbidity risk with antipsychotics in dementia patients. And you'll see from this list at the bottom that some of those are overlapping concerns for Parkinson's patients. Increased risk for diabetes, orthostatic hypotension, and we already recognize the significant autonomic dysfunction in Parkinson's patients, sedation, dizziness, constipation. So these are all side effects we're not eager to add to our Parkinson's disease patients, but yet are associated with antipsychotics, particularly low-potency antipsychotics. Point number 3. Parkinson's psychosis is highly associated with cognitive impairment. So this is a corollary to what I just said in terms of the risk for mortality being associated with dementia. Well, we know now, and have known for some time, that Parkinson's disease psychosis is also highly associated with dementia. So many of the patients we're treating in our clinical practice with Parkinson's disease psychosis have some form of cognitive impairment, whether it's mild cognitive impairment or dementia. And this is some literature illustrating this. This is from Dag Arsland's work. And it's really meant to just capture the fact that there are numerous non-motor neuropsychiatric symptoms in Parkinson's disease. You've heard about some of them the last few days. Many of them don't so clearly associate with cognitive impairment, depression being one example on the right of the slide, but psychosis, whether it be hallucinations or delusions, does very clearly track with significant cognitive impairment. Point 4, antipsychotics have now been associated in preliminary research, and this is research that I've been involved in, so I can point to most clearly. Antipsychotics have been associated with increased mortality risk in all PD patients. So this is from research that was published a few years ago now. This was using large Veterans Affairs, or VA, databases in the United States. These are veterans who receive their care through a national health care system for veterans. And there's good pharmacoepidemiological data available through that organization. So what we did here was, in a case control study, we took 15,000 Parkinson's disease patients and matched them to those who were exposed to an antipsychotic versus those who were not exposed to an antipsychotic, and looked at 6 months mortality and morbidity outcomes. And this is just a summary slide and not meant to go into great detail, but we found that any antipsychotic use compared with no use was associated with an increased mortality risk, and that this applied to both atypicals and typical antipsychotics, the atypicals being the ones that are more commonly used, medications such as quetiapine. So regardless of how we looked at it, and even when we looked at the individual antipsychotics that were prescribed commonly, including quetiapine, we saw that same increased risk. And in this study, we tried to match and control for as many variables as possible, although that you can only do so much with this kind of database. I also highlight on the right figure an important piece of information, what were the actual rates of mortality over 6 months in this observational study. It was about 5% in patients who were not treated with an antipsychotic, 10% in patients treated with an atypical antipsychotic, and 15% in patients treated with a typical antipsychotic, so one of the older ones such as haloperidol. So this is the mortality rate in this kind of a population over this length of period of time, 6 months. What was interesting from that study was that a chart diagnosis of dementia was only made in about 10% of patients. So we're not talking just about Parkinson's disease dementia patients here, but Parkinson's disease patients in general. In that study, we also examined morbidity risk. So these are the patients that survived the 6-month period They didn't die, but we wanted to look at what happened in terms of medical morbidity, and this is specifically, or most specifically, looking at emergency room visits and inpatient medical hospitalizations. And the antipsychotics were associated with an increased risk for both of those as well, compared with those patients not exposed to an antipsychotic. So this is just building the case for why in this population we should have concern about any antipsychotic use. Well, what about pimavanserin specifically? So this is a story. It's an evolving story, and this is a little bit of the background for the story. In the pivotal study that was published in Lancet about 5 years ago now, these were the serious adverse events that were reported. There was an increased rate, 11% versus 4% of participants in the pimavanserin group who had an SAE or serious adverse event compared with placebo. There was not as clear a pattern to those events. They were not so common that you could really discern a pattern, but the absolute rates were higher in the pimavanserin group. And 3 deaths occurred in that study, 2 in the pimavanserin group from sepsis and septic shock, and 1 in the placebo group from sudden cardiac death. So you can look at this 2 ways. You can either say that deaths were uncommon, this was out of about 200 patients, or you can say there were twice as many deaths in the pimavanserin group as there were in the placebo group. Subsequent to that study, and this is really fast forwarding to November of last year, a group in the United States called ISMP, they do medical monitoring of prescribing practices and clinical practice and adverse outcomes, came out with a quarterly report that looked at pimavanserin use since its approval, and it had been over about a 1-year period of time at that point. And what they had discerned from their reporting was that about 2,200 reports have been reported for pimavanserin, and I'll get into a little more detail about how these reports work. And deaths were reported in 2,244 of those cases. So that worked out to about 10.9 or 11% of the reports for pimavanserin involved death in some way. So this is where the rubber hits the road, really, and this is getting up to several months ago now in the United States. CNN came out with a report, and the link is at the bottom there if you want to read it, and it's titled, "FDA Worried That Drug Was Risky, Now Reports of Deaths Spark Concern." So obviously this grabbed a lot of attention. A lot of people look at CNN, and there's a couple of the quotes from the article. So, but the physician who led the FDA's medical review, so who was involved in the approval process for pimavanserin, warned that patients taking the drug during the company's clinical trial experienced serious outcomes, including death, at more than double the rate of those taking placebo. So this statement kind of combines the SAE events with the mortality events, because the mortality was 2 versus 1, whereas the SAE events were 11% versus 4%. The company's limited testing, he said, had not convinced him that the benefits outweighed the risk. In 2017, this is still from the CNN piece, an analysis, I showed you the highlights of that analysis, released by a nonprofit healthcare organization, the Institute for Safe Medication Practices, warned that 244 deaths had been reported to the FDA between the drug's launch and March 2017. That was that little table I showed you, 244 deaths. Since the Institute released its analysis, the FDA data shows that the number of reported deaths has risen to more than 700. And then just a little bit about that agency. It says, tracked by the FDA, these so-called adverse event reports document deaths, side effects, and other issues, and can be made directly by consumers, caregivers, and other medical professionals. So basically, once a drug is on the market, this is a mechanism for patients, providers, anybody to report that they are taking a medication, that they've experienced some outcome, whether they make a direct attribution in their own mind or not. And there's really no control over how this data is reported, but this is what was reported. This led to a recent medical editorial in Lancet Neurology, which I'll just highlight a few of the points here. In 2016, pimavanserin became the first antipsychotic to be recommended by the FDA for the treatment of PD psychosis. Comparisons with placebo indicated that there was an increased risk of death and serious adverse events, which was considered to be similar to other antipsychotics that are used off-label for the treatment of PD psychosis, such as quetiapine and clozapine. Since then, there have been numerous reports of serious adverse events, including deaths. So this is where we are. So what are the conclusions on the side of the argument that I'm on? So why should we worry that pimavanserin might indeed, and to me that's really the key words here is might indeed, increase mortality amongst PD patients with psychosis. So I've highlighted already, and just to summarize, PD psychosis patients are already at risk of bad outcomes, including increased mortality. So they're a frail population that deserves our greatest concern. Antipsychotics increase mortality in general dementia patients, and PD psychosis is frequently associated with dementia. Antipsychotics are associated, or at least preliminary data suggest, with increased mortality in Parkinson's disease too, and not just in those with dementia. I would say there's a lack of evidence to date from controlled studies to suggest that the pimavanserin is different from other antipsychotics. We just don't know at this point. And recent claims made in the popular press, and I highlighted the CNN and also the medical literature, the scientific journal, raise questions that need to be answered. So what is the solution in my mind, and this is my last slide, is more research and time. That this question can only be answered through prospective randomized controlled trials, being the gold standard. Those are the least biased. There's been a recently completed Alzheimer's disease study with pimavanserin, and there's also an ongoing discontinuation study in multiple dementia populations. And these are the kind of randomized controlled data that will really shed more light on this issue. You can also use large-scale, well-designed case control studies to get at this issue as well, using things such as the Veterans Affairs databases that I mentioned in the United States, Medicare databases. It has to be in the United States from now because that's where all the data lies, and eventually in Europe as well. And eventually we'll be able to compare through these case control studies pimavanserin versus untreated patients and pimavanserin versus other commonly used antipsychotics. Thank you.
Next, we have Dr. Zoltan Mari from Cleveland, United States, to answer the question with "No, we should not."
Thank you very much, Dr. Frey, and I also want to thank the organizers for inviting me to speak, and I thank the audience to be here, even though this is applicable to the United States, and two delegates from the United States are arguing over something in a global conference, so thank you for that interest. But I think it does eventually apply in many ways, and I think the discussion is helping us understand some of these points beyond just the United States. So my name is Zoltan Mari, and I am currently working for Cleveland Clinic, but I'm in Las Vegas, Nevada, and that's where I work right now, where we have a Cleveland Clinic Luruvo Center for Brain Health, and I also hold some other positions at UNLV and Johns Hopkins, where I recently moved to Cleveland Clinic. So first of all, I'd like to acknowledge that, and I made it into my title, that I don't want to say that we shouldn't worry, because we always have to worry, and there are always risks, and I think it comes down to a careful assessment of risks and benefits. And I would like to make an argument that pimavanserin for PDP is at least no worse than other antipsychotics, and because of the benefits that it can provide, those risks are reasonable to take. And I'd like to show some data, and I'd like to point to the prospective data and some of the post-marketing data that were collected in a more scientific way than patient reporting. And I don't want to undermine the importance of case reports and anecdotes, but frankly, the FDA public reporting of adversities is difficult to put into scientific terms for the reasons that causality cannot be assessed, and obviously it has a positive reporting bias too. So I would encourage everyone to take this issue very seriously, but also consider that the public reporting of SAEs may not measure up in terms of scientific merit and value to the data that I'm about to show you. So a few points that I'd like to make to start. And one is that at the moment, in the United States, we don't have any approved therapies for psychotic symptoms in Parkinson's disease. And considering that, we need to really look at the risk-benefit ratio from that perspective. I think it's a very important point, and the FDA, for their action of making this in the category of breakthrough therapy designation, the fact that there is no other drug in this category or for the treatment of PDP played a very important role. Now, I think Dr. Weintraub mentioned in his last slide, and I think it's a very important point, that there is no evidence that any other antipsychotic, regardless of approval, is in fact superior to pimavanserin in two main important aspects. One is efficacy, that anything works any better for the treatment of hallucinations and delusions. And there's also no evidence that any other antipsychotic does worse with regards to SAEs, especially mortality. Now, if we accept the equivalence, or at least equivalence, between pimavanserin and all these other alternatives that are not approved for PDP, with regards to efficacy and adverse events, there comes a major difference, which wasn't on Dr. Weintraub's last slide, and I think it's important. That is, this is the only antipsychotic at the moment where we do not have significant concern about dopamine receptor blockade and therefore worsening of motor symptoms in Parkinson's disease. And that's very, very critical, because I'm not trying to question the concern in the frail, demented, elderly population of any antipsychotic. But here in this debate, we are focusing on PDP, specifically in Parkinson's disease psychosis and psychotic symptoms. And therefore, because we are talking about Parkinson's disease in particular, the fact that we have an antipsychotic that has zero concern over dopaminergic receptor blockade is a very important difference. And not only that, it is studied and proven in basic science experiments. In fact, the pivotal trial as a secondary outcome showed no worsening of UPDRS scores in the pimavanserin group. We also have to realize that PDP, not only that it has no current approved treatment alternative, is an important clinical issue. Patients who have psychiatric or psychotic symptoms, including hallucinations and delusions, suffer greatly, and this is a very disabling problem. I would say that the usual number, the 50% lifetime prevalence of PDP, may be a bit of an overstatement from the perspective of clinical significant impact, because many patients may be managed alternatively, but there are patients whose psychosis is severe and problematic, and no alternative adjustments such as discontinuing of dopamine agonists and other drugs may help them, and still they are not functioning. And so I do believe that we are looking at an important clinical need. Now, I also would like to include in my main points that when the approval did take place, besides the black box warning, the FDA and the applicant agreed, the maker agreed to a very rigorous post-marketing clinical safety monitoring, which is not generally done, and it's not standard. And I think this gives us an additional sense of safety in terms of monitoring. And also, I will show you a slide later on in which I outline how the distribution of the drug is currently done, and how it is very relevant as to how the adverse events are collected. And it's, I think, very important in pointing this out, because you can look at the post-marketing high rate of adversities, but you also have to realize that because of the direct contact with patients and care partners, you will collect a lot more adverse events that way, and this is exactly because of that mechanism. And 90% of the post-marketing adversities are due to that mechanism. I would like to continue to make a couple of additional points, and I think it was discussed briefly before. Mortality in this particular population, and especially when it comes to the causality, becomes very difficult. This is an inherently frail population with already a high rate of mortality. They are elderly, they have comorbidities, and they are almost always demented. And so even the placebo group will have high rates. The other point I'd like to make is that at the moment, if you look at all these serious adverse events and mortality, there is no clear pattern or consistency or repeatability with regards to the specifics of those serious adverse events. And also, we are currently not aware of any underlying biological mechanism of action that connects specifically this pharmacotherapy with those SAEs. I also want to mention that there was very significant review, additional and above and beyond what normally the FDA goes through. They invited a psychopharmacologic drug advisory committee, which included patient representatives, and it overwhelmingly voted for the approval. And as I mentioned, breakthrough therapy designation was based on the unmet need. I also would like to address the size of benefit, because that becomes a contentious point in terms of the risk-benefit assessment. A lot of critics are pointing out that on the SAPS-PD, only 3-point versus placebo was seen in the pimavanserin population. However, on that note, I'd like to point out that one, there was a very statistically significant difference, so the statistical significance was very high. And the other thing is that there were many patients who had much greater improvement. And this figure from the pivotal study 020, first author Dr. Cummings in Lancet, actually breaks it down in a way that tells you just a little differently how you can imagine or view that improvement. Yes, it is only 3 points, but if you look at the different categories of 1-point response or greater, 3-point response or greater, and so on and so forth, you can see that the pimavanserin group wins in every one of those categories, whereas in the worsened or no change group, it's the placebo that is far greater. And then there are some patients who have complete resolution of their symptoms, and also patients who have 10 points or greater. So when you hear criticism that this 3-point change is just too little to justify all the risks, think about two things. One, that there are patients who will not have any other way of getting better or improving in these symptoms. And two, there are patients who will see a substantial improvement in terms of their psychiatric or psychosis symptoms. Now, this is as of 2016, at the time of approval, based on all the studies that pimavanserin was used in PDP by that time. I'm going to show an updated slide right after this. But at this time, you can see that in terms of mortality per 100 patient years, pimavanserin indeed was around double. That was noted earlier by Dr. Weintraub. However, these are very small numbers. There was 1 death in the placebo group, 2 deaths in the pimavanserin group, and those 3 deaths, 1 was cardiovascular, so was the 1 in the placebo group, and 2 sepsis. Again, as I pointed out earlier, we lack a clear biological explanation as to why that should be related. By the investigators, these were not marked as causative or related. And also, these numbers are very small, so it is double, but at the same time, by chance, 1 person or 2 can die in this age group. Now, this is the updated slide as of April of 2018, which then shows all the combined aggregate data, this time much higher numbers here, placebo group 357 and 510 for the pimavanserin. And in this updated, which will include not just Parkinson's, but also Alzheimer's related psychosis, you can see that there is no difference between the placebo and the pimavanserin groups. Now, I'd like to move on to this crude mortality rates in antipsychotic trials, and you saw some of it in the previous presentation. And just to give you some perspective, in the placebo group, as great as 15th study and over 5,000 patients, you see that the 100 mortality per 100 patient years is at 13.2, comparing to the 10 or 10.9 that I showed you earlier. So that's comparable. And all of the combined antipsychotic and aggregate, we are looking at 20.7% mortality rate, 100 patient years. I'm just going to show this slide very briefly. This is the way that pimavanserin in the United States is currently being distributed. And due to the frequent contacts, there is a greater than usual opportunity for patients and caregivers to report adversities. And I believe that the fact that 90% of the reported adverse events coming through these channels is the explanation why the post-marketing adverse event rate is as high as it is. Moving on, I'd like to show you this slide again when looking specifically for PDP. The previous aggregate data I showed you was from all antipsychotic use. And in this case, in PD patients, the mortality rates are far higher. So you can see the Acadia post-marketing data, which is again the same number that we discussed in terms of the 100 patient year, 12.8, compared to 13 in the aggregate placebo group for all. So it's not different from that. But at the same time, if you look at the other antipsychotic, your numbers are much greater, and Dr. Weintraub has explained that. So that is reason for concern, but certainly these numbers are much higher than what we have for pimavanserin at this time. In terms of the Medicare data for all age-related standardized mortality based on Parkinson's disease and Parkinson's psychosis, we have a 28.18 for PDP. So that's quite high. So in summary, now we have 25 studies that we can look at all these aggregate data with large patient numbers. And the aggregate numbers show us that, yes, there is mortality in the pimavanserin group, but these mortality numbers at least are no greater than the alternatives. And I would like to offer also a currently under review paper by Dr. Irene Litvan in neurology, where at their center they compared the pimavanserin numbers with Seroquel, quetiapine numbers, and again, they documented no worse mortality numbers for the pimavanserin group. So in summary, we should be always concerned about risk, and there's a general concern about any antipsychotic that I wanted to highlight here. There is a general concern in the use of antipsychotic in the demented and frail elderly population. But when you consider that in the Parkinson psychosis population, you have very significant disability and sometimes no other options, then pimavanserin is no worse than any other antipsychotic, but it is better for not making the Parkinson motor symptoms any worse due to the lack of dopaminergic receptor blocking activity. And I agree with the conclusions of Dr. Weintraub that we need more randomized data, but I hope I made a case for at least considering the risk-benefit ratio in this way, and rather than based on CNN reports and sensationalism. Thank you very much.
We have time for a couple of questions. If you can come to the microphones on the side.
Yes, please. Miguel Coelho from Portugal. I would like to comment that RCTs are not the best way to capture adverse events. The best way is through pharmacovigilance and case control studies, and we have recent good examples regarding the sleep attacks and fibrosis with dopamine agonists that were not captured in the pivotal clinical trials. So what we should encourage is that physicians report the adverse events to the national pharmacovigilance networks of their countries. Thank you.
We might both have a response to that. I personally still think the randomized controlled trials are the best, although with the limitation that they're acute, at least in this field, that you get 6 weeks of data, 8 weeks of data. So if there's a long-term mortality risk, you won't be able to capture it in a 6 to 8 week period. But I think all the case control studies, and I have been involved in some, are fraught with so many potential biases, and you can only control for so many of those biases with many of these databases, that to me they're always still a step below the data you get from a randomized controlled trial. That's my opinion anyway.
I agree with that. I also prefer randomized clinical trials due to the factors that you mentioned, and especially with the public reporting, as I mentioned, we have a significant concern over causality and all these biases.
I have a different question, but just to point out what you're saying, I fully agree with you in the sense that clinical trials are sanitized versions of our patient population. So really pick the best patients for clinical trials. And what you're alluding to is that in clinical practice, we expand the coverage of patients and therefore include people that would have never qualified for clinical trials, from whom data will never be available. So that's kind of an important, I think that's what you were alluding to. My point is that we really don't have good background rates for mortality in these populations as far as natural history is concerned. So we have a data that is confounded by the multiple uses of different antipsychotics, and we have to sort of extract from that data what might the population we're targeting with pimavanserin be in terms of mortality. And my sense is, based on the data you both show, that there is definitely a high mortality rate, and the question is whether it rises above the 10 to 12 or so rate that you mentioned, 10% or so, in the population that it's exposed to, or at least presumably recipients of these treatments compared to pimavanserin. And is it fair to say that perhaps it isn't quite as high with pimavanserin, that the base rate in which on the populations that pimavanserin has been used is actually somewhat lower, and that perhaps there might be a benefit, if nothing else, no worse than the baseline rate?
Yeah, I don't know if I could answer that, or we can answer that question at this point. But your point, I think, is well taken, and a couple of things I was thinking about was, one, some of these mortality observational studies don't control for the use of antipsychotics or many other variables that may also be contributing to mortality, so they're somewhat limited. And I think the other thing, and it reminded me of some of the data that Zoltan presented, was we have to be careful about comparing across disease states and cohorts. So for instance, the pimavanserin pivotal trial excluded patients with dementia. Some of the Alzheimer's literature you're referring to only includes patients with dementia. They have Alzheimer's disease instead of Parkinson's disease. So we can only compare and contrast them with so much comfort because there's other variables at play that will contribute to the mortality.
So I agree, but in the context, I was combining those data was basically to show that there's barely any increase over placebo with regards to the mortality, at least in that data set. And if we accept that there is an increase in mortality, again, two questions we still have to tackle with. One is whether that minimal increase in mortality, if that there is one, again, we don't know, is something that is justified based on a very important clinical need. And the second concern I think that we still have is that we don't know why there would be a specific connection between those SAEs. I know that pimavanserin is a cation lipid drug that will be potentially causing phospholipidosis, and there needs to be more work done if to see that any kind of respiratory problems or cardiac problems could be related to that. But at this point, we don't have any specific connection.
Well, I have more, again, comment. Actually, Peter Heder from Vanderbilt University, PD Center of Excellence. Actually, I think we are comparing apples and oranges, actually apples and stones. But I would like to actually make a comment that actually FDA should be more worried that we have actually data for mortality in PDP for haldol, haloperidol, iCrunch, or even risperidol. I mean, basically, so there is a lot of room for improvement. Again, the question is pimavanserin worse than quetiapine, which is kind of unofficially gold standard, or clozapine? I mean, the other, but it's really disturbing to me. Actually, I kind of missed that in your study that there is a study for typical, there's a data for typical mortality in typical neuroleptics in PD psychosis, which I think is atrocious.
Right. So that data was a little bit old when we presented it. It was from 2008 and onward, and that was from a setting where not every Parkinson's patient, the VA system, is seen by a movement disorders neurologist. Men are seen by general neurologists or maybe even primary care physicians. And I think we found in that study that typical antipsychotics were still prescribed in about 20 to 30% of antipsychotic prescriptions. So it was a little concerning to us as well to read that. I don't think we have enough data about risperidone. The only other antipsychotic that's used commonly in Parkinson's disease is quetiapine. That's the only one where you have a large enough sample size to do any kind of comparative analysis, I think. Anybody else? Because this is all interesting. I think we'll be around if anybody wants to ask any questions or has comments afterwards. Oh, go ahead, please.
Dr. It doesn't work. Dr. Broussel from Lyon. I have a long experience with PD and psychosis, and to me, what was the important change was in 1999 when two studies, small studies, I agree, were performed in USA and France with Leponex, that means clozapine, with clozapine, with low-dose clozapine, and since then, and even before this study, I could see, and my colleagues everywhere in France, that clozapine with low dose was helping in a number of PD patients with this situation, which is a difficult situation, harmful situation for the patients. So, as from 1999, we do not use other neuroleptics compared to clozapine until recently when we could get quetiapine. But I agree that the other neuroleptics, including olanzapine, are dangerous, harmful in Parkinson's disease. But low-dose clozapine help. So I don't know if you have in USA also the way to practice with low-dose clozapine, or is it not regulated? I don't know.
Of course. We didn't really have a rebuttal back and forth, but I was going to comment to Dr. Mari that although you're right that the only FDA-approved medication for PD psychosis is pimavanserin, it's not the only efficacious medication, and you've just highlighted nicely that clozapine has also been shown to be efficacious, and yes, it is available in the United States.
I was tempted not to say anything, but in the UK, NICE has just required that everyone with Parkinson's has access to clozapine. That, when I challenged NICE about it, were they planning to mainstream clozapine, was precisely their answer was yes. I've been a clozapine prescriber for 10 years, but there is an extraordinary resistance to using a drug that requires blood testing and so on. And I think I'm one of the few in the country that is compliant with NICE. The first patient I prescribed clozapine to 10 years ago had been predicted to be in a nursing home in 2002, and she's still at home 20 years later. But at the time I prescribed clozapine, she was on 600 milligrams of quetiapine, and it was doing nothing. Clozapine has enabled me to see her 6 monthly. So I think some of this argument is about why would we use something that has been shown to work, like pimavanserin, and clozapine. Why do we insist on using drugs that have been shown probably not to work? And there's quite a lot of antipsychotic prejudice in this. And I think we have to be careful to avoid that.
We did look in our study of prescribing practices of clozapine, and it turned out that in our population, which was again thousands of veterans, clozapine represented less than 2% of all prescriptions, yet it's readily available. You just have to go through the routine blood monitoring. So I think clinicians and patients kind of vote with their feet about what they're comfortable taking or not taking.